Simulation-based learning in medicine. Simulation-based learning transforms medical education. It offers safe, hands-on practice for professionals and students. This approach enhances skills and patient safety. Simulation learning offers several key benefits across educational, healthcare, military, and corporate training settings. Here are the primary advantages. Safe learning environment. Learners can practice skills without real-world consequences, reducing risk and stress. Enhanced retention and engagement. Interactive, hands-on experiences help learners retain information better than passive methods like lectures. Real-time feedback. Immediate performance evaluations allow learners to correct mistakes and improve quickly. Skill mastery through repetition. Simulations can be repeated as needed, helping learners build confidence and competence. Realistic scenarios. Learners engage with lifelike situations that prepare them for actual challenges in the field. Critical thinking and decision-making. Simulations often involve complex scenarios that develop problem-solving and leadership skills. Teamwork and communication. Group simulations encourage collaboration, role clarity, and interpersonal skill development. Adaptability and flexibility. Simulated environments can be tailored to different learning levels, objectives, or changing conditions. Cost efficiency over time. Although initial setup can be expensive, simulations reduce long-term training costs, e.g., materials, travel, instructor time. Performance tracking and assessment. Data collected during simulations can be analyzed to identify trends, strengths, and areas for improvement. Simulation modalities refer to the various types or methods of simulation used in training, especially in healthcare, aviation, military, and other high-stakes environments. Each modality varies in complexity, realism, and educational objectives. Here are the main simulation modalities. 1. Low-fidelity simulation. Description: basic models that focus on specific tasks or skills. Examples: CPR manikins. Intravenous, 4, arm models. Suturing practice pads. Purpose: skills acquisition and repetition without realistic scenarios. 2. Medium fidelity simulation. Description: more advanced than low fidelity, these models may include partial physiological responses or limited interactivity. Examples: manikins with breath sounds and heart tones. Simulated wound care on a manikin torso. Purpose: practice clinical assessments and decision-making with some realism. 3. High-fidelity simulation. Description: realistic, computer-driven mannequins that simulate human physiology in real time. Examples: Simman, Lairdal. Hal, Gomard. Purpose: critical thinking, teamwork, communication, and crisis management. 4. Standardized patients, SPs. Description: trained actors who portray patient cases consistently. Purpose: practice of history-taking, communication skills, and physical examinations. 5. Virtual reality, VR, and augmented reality, AR, simulation. Description: immersive computer-based environments with 3D interaction. Examples: VR surgery training. AR anatomy overlays. Purpose: enhances spatial awareness, procedural training, and immersive learning. 6. Screen-based simulation. Description: computer-based scenarios with interactive decision-making. Examples: virtual patients. Diagnostic decision software. Purpose: clinical reasoning, diagnostics, and pathophysiology understanding. 7. Hybrid simulation. Description: combines two or more modalities for enhanced realism. Examples: a standardized patient wearing a part-task trainer, e.g., for arm. Purpose: multimodal learning that addresses technical and communication skills. Integrating simulation into the medical curriculum is a powerful approach to enhance clinical competence, critical thinking, and decision-making skills in a safe, controlled environment. Here's a structured overview of how to effectively integrate simulation into medical education. 1. Rationale for simulation in medical education. Simulation-based education allows learners to practice procedures without risk to patients, receive immediate feedback, develop clinical reasoning and teamwork, experience rare or complex clinical scenarios. 2. Types of medical simulation. Manikin-based simulation, for procedural skills e.g., CPR, intubation. Standardized patients, actors trained to simulate real patients for communication and history-taking skills. Virtual simulation, computer-based, VR, or AR simulations for diagnostics and treatment planning. Task trainers, devices to practice skills like suturing or fore insertion. High-fidelity simulation combines mannequins and realistic clinical environments to simulate acute care. 3. Steps to integrate simulation into the curriculum. A. Needs assessment. Identify gaps in current training. Determine which competencies can be better achieved via simulation. B. Curriculum mapping. Align simulation activities with learning objectives and accreditation standards, e.g., AAMC, LCME. Ensure integration at multiple levels, preclinical and clinical years. C. Development of scenarios. Create evidence-based, standardized scenarios with clear objectives. Include a range of cases, common, rare, emergency, ethical dilemmas. D. Faculty training. Train instructors in simulation facilitation, debriefing techniques, and equipment usage. E. Implementation. Introduce progressively complex simulations. Include interdisciplinary scenarios to promote team-based care. F. Debriefing. Critical component, structured reflection post-simulation to consolidate learning. G. Assessment and feedback. Use formative and summative assessments. Incorporate checklists, OSCE-style evaluations, and peer reviews. H. Evaluation and continuous improvement. Gather student feedback. Monitor outcomes, e.g., skill retention, clinical performance. Revise simulations and curriculum based on data. 4. Challenges and solutions. Challenge solution. High cost of simulation centers use mobile or shared simulation labs. Faculty resistance offer workshops and incentives for involvement. Time constraints in curriculum integrate into existing courses or clerkships. Technical issues provide dedicated tech support and maintenance. 5. Examples of integration points. Preclinical years, anatomy and physiology using AR/VR. Clinical skills courses, physical exam on standardized patients. Clerkships, emergency simulations, code blue drills. Residency preparation, high-fidelity trauma simulations. Simulation has become a cornerstone of medical education and training due to its ability to provide safe, controlled, and repeatable learning environments. The evidence supporting its use spans various domains, including skill acquisition, team communication, patient safety, and outcomes. Here's a summary of key evidence. 1. Improved clinical skills and performance. Procedural competence. Studies show that simulation improves performance in procedures such as central line insertion, laparoscopic surgery, and airway management. Example, a 2011 meta-analysis, McGaggy et al., Academic Medicine, found that simulation-based education with deliberate practice outperforms traditional clinical education in achieving procedural competency. Retention of skills. Simulation training has been shown to enhance both short and long-term retention of clinical skills. 2. Enhanced patient safety. Error reduction. Simulation training is associated with reduced medical errors, especially in high-risk settings like anesthesia and emergency medicine. Example, implementation of simulation-based training in obstetrics has reduced shoulder dystocia-related injuries, Draycott et al., BJOG, 2006. Crisis resource management. Teams trained in simulated emergencies demonstrate better teamwork, decision-making, and outcomes under stress. 3. Improved teamwork and communication. Simulation enhances interprofessional education by training teams to work effectively under realistic conditions. Example: Team Steps and CRM, Crisis Resource Management, simulation have improved communication and reduced sentinel events in clinical practice. 4. Objective assessment and feedback. Simulation allows for objective, standardized assessment of learners, supporting competency-based education models. Tools like OSCEs, objective structured clinical examinations, and high-fidelity manikins enable real-time feedback and debriefing. 5. Cost-effectiveness and ROI. Though initial costs can be high, simulation training reduces downstream costs by lowering error rates and malpractice risks. Example: a study from the American Journal of Obstetrics and Gynecology, 2011, showed simulation training in labor emergencies was cost-effective by reducing adverse outcomes. 6. Ethical and safe learning environment. Simulation offers a safe space to learn from mistakes without risking patient safety. It enables practice on rare or high-stakes scenarios that may not arise frequently during training. Key publications and reviews. McGaggy W.C. et al., 2011. A Critical Review of Simulation-Based Medical Education Research, 2003-2009. Medical Education. Isenberg S.B. et al., 2005. Features and uses of high-fidelity medical simulations that lead to effective learning, a Beam systematic review. Medical Teacher. Cook D.A. et al., 2011. Technology-enhanced simulation for health professions education, a systematic review and meta-analysis. JAMA. Challenges and limitations. High costs. Simulators and facilities require significant investment. Time-intensive. Setup, execution, and debriefing consume valuable time. Technical issues. Equipment malfunctions can disrupt sessions. Future trends in simulation. Enhanced VR and AR. More immersive and realistic procedural training. AI integration. Adaptive learning and personalized scenarios. Remote simulation. Access training across locations worldwide. Key takeaways and next steps. Adopt simulation. Incorporate into medical training programs. Provide resources. Invest in equipment and faculty training. Evaluate outcomes. Use data to refine and improve simulations. Embrace innovation. Explore emerging technologies to enhance learning.